This is the Doc Nation podcast. We are a movement founded by doctors, for doctors, dedicated to empowering medical professionals to reclaim control over healthcare decisions and advocating for their fair share of the industry's resources. Please note, the views expressed are those of Doc Nation and not necessarily those of our guests or referenced health centers.
Dr. Stout, thanks for being
Hi.
with us.
Thank you very much for inviting me. I'm glad to be here.
Oh, I love it. Had you seen some of our podcasts in the past?
I watched a couple, not very many, and I did not all of them all the way through, but I got a feel for it. So
we haven't actually had a chance to meet. Can you give me a little bit more of your background?
yeah, for sure. I'm Dr. Jaron Stout. I'm a pharmacist, and I have a very unique practice that's kind of on the cutting edge, I guess. But I'm trying. So, I mean, just a very brief background. A consultant pharmacist is a required service in skilled nursing facilities. I don't know if you knew that.
Okay.
It's their job to make sure every resident's medication is reviewed every month. And so I was hired as a consultant pharmacist early in my career, shortly after I graduated. And I quickly realized that it was not the service that it needed to be to meet the need of the population. And so I've made it my mission to kind of raise the bar on the standard of practice and how it's handled. And that includes very thorough collaboration with medical groups and using the available billable mechanisms to enhance the services and extend the reach of the physicians. So that's a oversimplified way of explaining it.
I have questions here, right?
Yeah.
Now, anytime, obviously you're kind of exercising your leadership and doing things like this on a podcast and stuff like that. So, but when you mention the word mission, I want to know like what really is that mission and what's driving that? Like what's going on there that needed to be kind of revamped?
All right. So just as a background of what typically happens, when I was first hired, I was trained to show up, crank through as many charts as you can, as fast as you can, and I worked for a pharmacy, which technically there's an inherent conflict of interest. There's no incentive to get rid of unnecessary meds because it technically hurts their bottom line. There's no incentive to do a good job because no matter how good you are, you're going to lose your job as soon as they hire a new pharmacy. So there's some problems with it. I was trained to show up, and if you find someone's on aspirin and Plavix, then that means you make a recommendation saying, "Hey, we need to monitor for bleeding." And very early in my career, I remember seeing a nurse, and she was telling me, "Jaron, why do you tell me to monitor for bleeding? I'm a nurse. I do that every day, whether or not you recommend it. Whether it doesn't matter what drug they're on, I'm already doing that." And that changed my perspective. And I started to think, oh, well, you're right. What should a pharmacist be doing? Like, what kind of recommendations should we be making? And so instead of identifying bleed risk, I identified when the meds were present that would increase the risk and identify if they were appropriately used, because not everyone should be on dual antiplatelets for extended periods. So identify if it was for a stroke, and if so, that's usually a very short-term regimen. So that's one way of putting it. And I would say that the mission is because that kind of started it. And I also had a nurse early in my career who said, "Jaron, we love having you here, but we know when you come here, you're just going to give us a stack of paperwork." And so I've looked for ways to simplify it so that I'm not adding to their workload, but instead I'm doing a collaborative practice with the physician to where I show up, implement changes on their behalf, and then give the nurse a stack of paperwork that says, "Here's all the stuff that I did to fix your facility and the medications today." And so I started a collaborative practice. I created my own company. I broke free from the dispensing pharmacies, and I've taken over 50% of my market in the state that I live in Utah. And I've also created a coalition. I go to DC and I do a lot of advocacy on how physicians and pharmacists can do more collaborative efforts. And I know CMS has a lot of interest in more team-based approaches and practices. So this has been received well all around so far.
Justin.
I'm mission. Yeah. So
Yeah.
one of the things that I think people wonder about Doc Nation is Doc Nation just for doctors? Is it for anybody else? And actually, yes, it's very much about patients. We want to restore the relationship between doctors and patients because there's been a huge wedge that has come between that relationship. And that relationship is so key, and having time with your patient and
Right.
what you're talking about, actually making sure that the way that they're being treated with their medications and the regimen and what they're doing, that a holistic process for getting the care for your patient the way that they should be taken care of, that's so critical. And you said earlier that bottom line for these businesses gets in the way, and that's a problem. And we're all about business. We are pro business. We love business. It's our favorite thing is to see business flourish for our clients in whatever way that they're doing their practice. But the business, the corporate side should not get in the way. It should not disrupt the relationship and the quality of the care. That's why it's 2024 and we should have the best outcomes, the best healthcare ever that has, we have all these innovations in technology and everything else. And for some reason, healthcare is actually going the opposite direction. It's the opposite of what it should be. And why is that? It's because the healthcare provider and the patient don't get to have the relationship that they're supposed to have. So Doc Nation is not just about doctors. It's way more than that. It's about the relationship that they get to have with their patients. So I love what you're doing here because you have seen that there's something competing with the quality of care. So can you maybe speak to that a little bit more? Because even the patients, the non-medical professionals that tune in and listen into this, they need to know that, because I think, is my doctor the problem? Is it the insurance company the problem? What's really the problem here? Like, patients need to know that doctors really want the best for their patient, but there's a constant fight that they have to put up with. So tell us more about that.
Yeah. So, I mean, as you know, healthcare unfortunately has created a system that has become very much volume driven. So you're compensated well to crank through the patient visits more than you should, and so one of the ways to remedy that currently is, well, let's just throw more providers at the problem. Now, keep in mind, more providers is great, and we obviously need more providers because we have a giant gap that continues to grow in the number of providers available, especially on the front lines in primary care. And just to the best part, so rather than throwing more of the same old stuff at it, as like you said, things are kind of going in the wrong way. Rather than throw more of the same old stuff, if we include a new perspective and a more collaborative approach, I think that's going to enhance the patient care significantly. And the best part about that is you don't need to give provider status to pharmacists. And I'm not advocating for provider status because we can make a difference right now with the billable mechanisms that are already in place. As long as we work for a medical group, under a medical group, we can extend the reach of those physicians under their supervision. Whatever, it's not like you're just handing over the keys, although some physicians would like to do that. You literally only delegate what you're comfortable delegating. And in the case of a pharmacist, you have to realize that we're not diagnosticians. We're not trying to be diagnosticians, but we have been very thoroughly trained on how to manage chronic disease states and treat them pharmacologically. And it's like kind of ironic that more and more pharmacists are becoming more functional medicine based because we see that we're right now over medicating a lot of people. And polypharmacy, and the most common intervention in healthcare right now is adding a medication. Well, when you start a medication, you're never, ever, 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 ever fixing a problem. You're trading it in for a new one. And so if you have a pharmacist on your team who has that perspective, then we're able to reverse engineer what medications are creating new problems that we weren't identifying that resulted in more medications being added on board.
So I
And
love that. Hold
so,
on one second, if I can interrupt
yeah,
you.
yeah.
Are you gonna get in trouble because you just said that? Like, I feel like that's something, like, you just said the thing that like the drug companies don't want to be heard. Like, for patients that are tuning in, like, absolutely, this is exactly the kind of intel that should be shared. Like, who are you gonna get in trouble with when you talk like that?
That's
Justin, that's who we are. It's like Doc Nation, we say the quiet part out loud.
Yeah.
right.
And
That it enhances good care, right? You know, and
Good point.
yeah, I mean, it's funny you would say that. I tend to perhaps not, I wouldn't say offend, that's too strong of a word, but rub some people the wrong way in how I approach that. Especially since I no longer work for a pharmacy. It's so hard for me to be defined in my practice now, because technically when a pharmacist steps out of a pharmacy, they're not defined in how they practice at all. We're literally confined to a box where we can practice, and I am an out of the box thinker. And so it's made it so that it's, some people don't like, not very many, I would say the vast majority like what I do and they agree with what I do. And like you said, it's just the quiet part out loud that we need to find non-farm. And that's another aspect I'll get into. You asked, so if right now providers are incentivized to have an intervention in their during their visit, because that allows them to bill for a higher complexity. What we need to do is identify more interventions that are not drug based. And if we have more ways of intervening and providing care plans that don't include adding a new medication, then we can still bill for those higher complexities and perhaps even have better outcomes. Because a lot of drugs, like I said, are just a trade off, and we're creating new problems down the road.
And this
now
is
has
precisely
this
why the consulting for these patients is key, because who is advocating in this way? Like,
Right, yeah. And you know, like I said, it's a new perspective. So when a physician sees a patient, they make a diagnosis. They see the patient, make a diagnosis, and move down to medications. A pharmacist does the exact opposite, and it's really synergistic and very complementary. We start with the meds and then work our way up to their conditions, and then talk to the patient about what our findings are. And you'd be surprised how well that works together. I have tons of examples I could give.
that's really encouraging. That type of collaboration. How much of this message has reached DC? You mentioned some advocacy there.
So I created a coalition, and it was mostly because we wanted to bring a case to CMS and let them know, here's what the incident to laws or regulations state. Here is how vastly different they are being interpreted from one MAC provider to the next. Here is all of the misunderstandings that we have identified. We need a public clarification. Yes, pharmacists can be auxiliary personnel. Yes, they can do incident to in nursing facilities. Because there is a ton of medical groups and MAC providers that are all interpreting it differently. And even though I personally have received confirmation from CMS in an email that, yes, I interpreted it correctly, because I kept going up and up and up the chain. Everyone didn't know how to answer my questions. So finally, they forwarded me to a rep at the CMS office in Denver. And so we wanted to get a public clarification. When I created the coalition, that was kind of the goal. However, with the flexibilities in place with COVID, it wasn't like a high priority. So we kind of put that on the back burner. And now it's been mostly just spreading the word, with occasional visits to my senators and a few other senators, depending on who's with me when I go to Capitol Hill. So it's still not widely known because we're a pretty small niche that I'm hoping to change that. I would say if what I do works and what I'm trying to do works, it could quadruple the number of consultant pharmacists that provide care in nursing homes. And significantly enhance what they're doing to begin with.
Okay, so let's get the word out right now. All the other pharmacists or consultants out there, they need to do what?
Well, the
Contact
unpopular.
you and get a game plan.
Yeah. I think the unpopular opinion, many people would disagree with me, but I love the fact that we've provided products for ages and ages, but we can't be a one-trick pony. I would say break free from the pharmacy, do this on your own. Pharmacies are great at what they do, but they're not great at understanding how to bill for time, because that's the biggest obstacle we've had. We've only been able to bill for products for ages and ages and ages. So when we have the opportunity to bill for our time, it turns into what product can we base this on? So let's do lipid screening so we can hand out more statins. Let's do COVID tests so that we can hand out more COVID treatments. Little things like that. I would say create your own thing, and like you said, reach out to me. Go and if you're a consultant pharmacist, you should already have good relationships with several providers. Team up with providers, start offering enhanced care through Incident 2, through CCMs, through BHI, and annual wellness visits to extend the reach of those physicians, and use those billable mechanisms to extend the reach and enhance the care.
There's already a provision for this. There's a requirement, as you mentioned at the very beginning, as you get your background, that this is a requirement to be available. It's not being filled.
Right.
And the reason why pharmacists don't know this or unaware, or they're not pursuing it, is what's stopping them from fulfilling
several things.
What's already required to be in place that should be there for their own benefit of the patients that are living in these facilities.
Not sure I understand the question. So, what are you asking? I'm not sure I understand.
Well, they're supposed to have a consultant, you said, right?
Okay, yeah.
For every however many patients that live in these facilities, they need to have somebody that's helping provide leadership in this way. And there's a hole or a gap that this role is not being fulfilled by people that could do it, doctors like you. So is there a reason why they don't know about it, or they're not pursuing it? What's the holdup there?
Okay, yeah, sorry. So I think part of it is just you're taught how to do a task, and typically pharmacists like to stay in their little box. So as soon as you're trained on, hey, show up, if you see DocuState, try to get rid of it or recommend getting rid of it. Basically it comes down to education and training. Most of them don't even know that these opportunities are available. And it's funny because CMS publicly stated or answered the American Academy of Family Physicians in 2014. Yes, pharmacists can work in a clinic and they can operate as Incident 2 in a clinic. But despite that, none of the pharmacy organizations have really promoted that. None of the pharmacy schools have really promoted that. No, there's not a lot of education or understanding on how you can collaborate with physicians. I'm trying to make it so that I've collaborated with where I went to pharmacy school, trying to get them on board with providing a course. Because the problem is when you graduate from pharmacy school, you're 6 figures in debt. And then you find out that these opportunities are available. So now you have to pay other pharmacists that are out there teaching other pharmacists how to do this. And then you go another 4 or 5 figures in debt trying to figure that out, because there's a lot to understand in how to bill for your time that pharmacists are not trained on, that physicians are routinely trained on. So a big aspect of that is A, education, and B, how it's regulated. Because right now, if the flexibilities go away, there's going to be a lot of restrictions that are coming back that complicate it. And just one last thing on that. General versus direct supervision. I assume you know what that is in the Incident 2 regulations. But direct supervision, that works great in a clinic. But in a nursing home, it actually complicates things. In fact, if you are a physician in a medical group, you have a physician and a nurse practitioner, you schedule your visits to stagger so you're not in the building at the same time or on the same day. Otherwise, your visits might overlap, and that creates problems because you can't bill for both those visits.
Yep.
Now, under direct supervision, if you have a pharmacist working for the physician, you would have to be in the building at the same time at the same day. Then you have to do a lot of heavy coordination. Okay, you're going to see them. Okay, I'll put my visit with them off till another day. And if you're there once a week, sometimes you're waiting 1 or 2 or 3 weeks to see the patient that you found a problem with. And so technically, direct supervision in nursing facilities is a very bad way to go about providing this care. I hope that answered your question.
Think about that part.
Yeah. Does.
Wow.
Yeah.
So what, even hearing this as a patient, or me, I got to excuse my ignorance a little bit. I didn't know a lot of this stuff coming in here.
Yeah.
What can we do? What do we need to look out for?
I would say, if you look at the AMA's website, they actually offer a course on how to hire a pharmacist and implement a pharmacist in your services.
Okay.
And nobody knows about it. But basically what it says is you can just do a small pilot, bring them in, give them some of your most complicated cases. And from there, you can identify where their strengths are and kind of build on it from there. I would say that's a very effective way to go about it. And also look at where pharmacists have been proven the most valuable. They've been proven valuable in diabetes management, anticoagulation management, COPD. A lot of the big heavy hitters, chronic disease states that are problems in our country are areas where pharmacists thrive. And that frees up the providers to start identifying and diagnosing new problems with patients. They're freed up to the day-to-day management of chronic disease states to kind of delegate that to a pharmacist. So those are very effective ways to start with. And just on that anticoagulation topic, I literally just published an article on October 1st, a study that I did with a group over 8 states. We were able to show that a DOAC, direct oral anticoagulation dosing, is vastly misunderstood. And we found that consultant pharmacists can and should be making a huge impact to make sure they're dosed appropriately. In fact, I think the number's inflated, but we found 85% of oral anticoagulation was inappropriate. And so it's really hard to stay on top of that while managing and all of your patients from day to day. So having a pharmacist on board just helps improve that care. Healthcare is getting more complicated, as you said.
Neil,
I hope that answered your question.
Yeah, it does. And Neil, I think we should make sure that we get that link to that course so we can have that with this. So after listening, go jump on to our webpage and go pull that down. You talked about the pipeline, like the education process. Government and these healthcare institutions, what do they want? They want workers. They want you to be a worker, not a thinker. They want you to be a doer, a taker of orders, being told what to do, not to think for yourself. So I really appreciate you stepping out, being courageous, being bold, stepping into bravery to say, actually there might be a better way to do this. And it's going to be good for me to think a little bit for myself, because as you think for yourself, you are giving others the opportunity to think for themselves as well. So thank you for taking the step and being bold to go against the grain a little bit. Like,
yeah,
some people
to get it out there and share with others.
Yeah.
Like thank you for bringing this to Doc Nation.
Yeah. We look forward to watching you as you continue to champion this for the sake of the community benefits, because as you said, it's never solving a problem. Truly, there needs to be other things that get brought in. So I appreciate your holistic perspective and not just being that one trick pony, which the industry is just so plagued with. So we look forward to watching you as you continue to fight this fight.
Well, thank you. I'm just honored with the invite and happy to come here anytime. So thank you.
Don't be a stranger.
Yeah, you as well.
This has been the Doc Nation podcast. If you like what you heard, be sure to subscribe, rate, and leave us a review on Apple Podcasts, Spotify, or wherever you are listening to us. Your feedback really helps us reach more listeners like you. We'd also love to hear your thoughts and any topics you'd like us to cover in future episodes. Don't forget to follow us on Facebook, Instagram, and LinkedIn for updates, behind-the-scenes content, and to join the conversation. Thanks for listening.